there is dorsiflexion of the toes, that is a positive Babinski reflex. It can also be demonstrated by firm pressure along the anteromedian surface of the upper tibia, termed as Oppenheim's sign. And it can also be demonstrated by squeezing the Achilles tendon, termed as Schoffer's sign. Radial palsy. Note the wrist drop on the left side due to radial nerve palsy. The fingers can be extended because the interossea are supplied by the ulnar nerve, but the wrist, the thumb and the metacarpophalangeal joints of the fingers cannot be extended. Now watch the brachioradialis muscle in the normal right hand as it stands out when a mid-prone forearm is flexed against resistance. But on the affected side, it does not contract and remains soft. Now here I have marked the area of anesthesia, which is characteristic of radial nerve palsy. Note that within this area, the patient does not feel the pinprick, but outside it, the sensations are normal. Now this is a ulnar claw hand deformity affecting mainly the little and ring finger due to flexion of interphalangeal joints with extension of metacarpophalangeal joints following ulnar nerve injury. Note the wasting of hypothenar and thenar eminences. Now compare it with a classical claw hand which occurs in ulnar and median nerve injury, brachial plexus injuries, leprosy, cervical rib and spinal cord lesions like syringomyelia. Now we shall see a few involuntary movements. When a young child comes with irregular, senseless movements, he is not affected by any ghost. He is affected by rheumatic fever and is having rheumatic chorea. If the patient is adult, then of course it is unlikely to be rheumatic. Then you should think of other causes, especially hysteria. Watch the boy as he is trying hard to hold his hands steady, but he cannot. The chorea is involuntary and he cannot control it. It usually persists even after treatment for 3 to 6 months. Everyone must have seen senile tremors. They mainly affect the hands and the neck. There is no definite treatment for senile tremors. B complex and tranquilizers may show temporary benefits, but these tremors have to be accepted. If the tremors are more on one side of the body or are accompanied by rigidity and mask-like face, then think of Parkinsonism. Watch the mask-like face without any expressions. There is hardly any movement of the facial muscles when the patient is talking. Only the jaw is moving. This is a mask-like face of Parkinsonism. Watch the tremors of the hand. Watch the imbalanced gait and watch the typical pin rolling tremors of Parkinsonism. Chest. Here we have a pigeon chest. Note the forward projecting sternum and costal cartilages. It may be congenital or secondary to rickets or chronic nasal obstruction in childhood. A pigeon chest where the sternum and costal cartilages are projecting forwards. This is a funnel chest or pes excavatum. Note the exaggerated hollow over the lower end of the sternum. It is often seen in cobblers due to constant pressure of the shoe against the lower part of the sternum, or it may be due to rickets or congenital. It has no specific significance, but in severe cases the heart may be displaced to one side. Now this is a rickety chest with rickety rosary due to bead-like enlargement of costochondral junctions. Watch the two rows of visible beads on either side of the sternum. They are close to the sternum in the upper chest, while the lower ones are situated more laterally. 4th, 5th and 6th costochondral junctions are particularly more enlarged. This is another rickety chest with pigeon chest deformity, that is protruding sternum and Harrison's sulcus. See the transverse grooves along the attachment of diaphragm where the soft rickety chest gets pulled in during inspiration. Watch this chest carefully. You will notice that the apex beat is on the right side. This is a case of dextrocardia. An X-ray will be confirmatory. What you have to remember is that in some cases with dextrocardia, even the abdominal organs will be inverted. So spleen will be on the right side, liver on the left side, and the pain of acute appendicitis is in the left iliac fossa. Watch again the apex beat on the right side. Now in this patient, note the bulging precordium. This is an indication of cardiomegaly. The heart lesion needs to be examined and investigated carefully. The apex beat is heaving, a sign of left ventricular hypertrophy. Watch the bulging precordium and the heaving apex beat. Watch the sustained systolic elevation of the apex beat. Heaving apex beat of left ventricular hypertrophy. Here I am testing for left parasternal heave, which is absent. That is, clinically there is no hypertrophy of the right ventricle. Now in this patient, compare the left side of the lower chest with the right side. The left side shows fullness, the movements are diminished, and the intercostal spaces are relatively bulging. On the normal right side, the intercostal spaces are retracted during inspiration, but on the left side, they are bulging. This type of fullness indicates fluid in the pleural cavity, like pleural effusion or empyema. Watch the minimal retraction and actually bulging of the intercostal spaces on the left side. Now I am aspirating fluid from the right chest, and we will see the same case after aspiration of 1200 ml of clear straw colored fluid. See that the fullness of chest has reduced. Intercostal spaces now retract during inspiration. This is another similar case with fullness on the left side. But note the intercostal tenderness. If the intercostal tenderness and fullness is present on the right side, then in addition to empyema, you have to think of amoebic hepatitis, which is more common. This was a case of amoebic liver abscess. Watch the intercostal tenderness on the right lower chest. An intercostal tenderness at this site, you must suspect amoebic hepatitis. Now here we see a diffuse chest wall swelling, tender and warm, over the left upper chest. But the interesting feature here is that when the patient coughs, the swelling bulges. This is an empyema which has tracked to the subcutaneous tissues called as empyema necessitans. Watch the expansile impulse when the patient is coughing. This brings us to an important clinical rule that whenever a swelling is seen on the chest, you must look for cough impulse. See this cold abscess on right parasternal area. The positive cough impulse indicates an intrathoracic or pleural communication. While examining right parasternal and back swellings, in addition to cough impulse, you should also look for pulsations. This is a case of aneurysm of ascending aorta. It looks exactly like a cold abscess, but it is pulsatile. So before trying to aspirate a cold abscess on the chest wall, you must look for cough impulse and pulsations. Watch the expansile pulsations of aneurysm of aorta. See how the fingers move away from each other with each pulsation. Expansile pulsations of aneurysm of aorta. Lastly, we will see a flail chest. Such serious injuries are not seen in general practice, but watch it just for the abnormal movements. Double fractures of adjacent ribs produce a freely mobile segment of the chest wall, which is drawn in during inspiration and out during expiration, exactly opposite to the rest of the chest wall. This is a very serious injury that may need to be kept on a respirator and artificial ventilation immediately. We will also see another very interesting sign in this case, that is surgical emphysema. Surgical emphysema occurs due to air in the subcutaneous tissues, which produces a crackling feel to palpation. See the swelling in the right side of the neck, and when I palpate it, you can actually see the displacement of air in the subcutaneous tissues. This type of surgical emphysema is often felt around fractures of ribs. But if such crackling crepitations are felt around an infected wound, you should immediately think of gas gangrene or similar anaerobic infections. Enlargements of thyroid gland are of common occurrence in females, and the upward movement during deglutition is almost diagnostic. During examination, we have to see whether the goiter is diffuse, multinodular or a single nodule, whether it is toxic or non-toxic, and benign or malignant. Around puberty, the entire gland hypertrophies slightly and in some cases remains quite prominent for 3 to 4 years. This is called puberty goiter. If it is too large or persists after the age of 20 years, then it has to be removed. This is a single nodule on one side. Though clinically it is a single nodule, there may be many small nodules in the gland. That is a multinodular goiter with a single large nodule. If the rest of the thyroid gland is palpable, then clinically we consider it as a multinodular goiter with a single large nodule. This is a multinodular goiter with enlargement of both the lobes and the isthmus. These goiters are common in endemic areas with iodine deficiency. Multinodular goiters can sometimes grow very big. This particular multinodular goiter had compressed the trachea and was causing respiratory stridor. The trachea had become so compressed and soft that this girl needed a tracheostomy for a few days after removal of the gland. When such a large goiter is seen, malignancy also should be kept in mind. Watch the slight upward movement during deglutition. It will not move up freely, mainly due to its weight. If the goiter is hard or rapidly growing, especially if the patient is old, then malignancy has to be suspected. The signs of malignancy are rapid growth, hard consistency, fixity to the surrounding tissues, and inability to feel carotid pulsations. Note the white sclera beneath the limbus between cornea and lower eyelid. If the eyes are prominent, if the patient has tremors, and if the pulse is faster than 100 per minute, suspect thyrotoxicosis.